Welcome everybody to our second day of Cohort 4 report back presentations. We're really excited to hear about the great quality improvement work that you've been doing the last 9 months. My name is Ash Coster. I'm a program manager for the E-QIP project, which you would all be very familiar with. I'm joined today by my colleagues, Noshaba Degani and Debbie Bang, co-directors of the E-QIP project. Amy Patel is on the line. Our wonderful coaches, Laura, Linda, Abel, Rishi, and Melanie. So welcome, everybody. Really excited to hear back from you today. If we could just go to the next slide. And for those that just recently joined, just a reminder that this session is being recorded, and we will be sharing this on our YouTube channel as well as our website, just so we can foster that learning and engagement with QI work and provide a little bit of teaser for those that may be interested in starting a QI project of their own. Just go to the next slide. I'm just seeing the title live currently.
Oh, you're not seeing the agenda?
I am not.
Oh my goodness. Are you seeing any, am I scrolling now? No? All right. I'm going to stop sharing and start sharing again.
Okay.
I'm going to do this. Sorry, talk amongst yourselves.
Okay. Happy 4th Wednesday.
Wednesday, oh my gosh. I've totally adopted them.
If it's not Friday, I've decided it's Wednesday. There's 4 of them per week. Okay. You're not in presentation view, but I can see the agenda now.
All right, there.
Now there we go.
All right. And I'll close the chat. There you go.
Sweet. Thank you. So, if I had just memorized this, this would have been okay. Today we're going to hear back from CMHA Middlesex, followed by Crossroads Center, CMHA Windsor Essex, Renaissance, and we'll do an overview of sustainability and spread at the end. You can see the presentations that we had earlier this week, Tuesday or second Wednesday, which has been posted to our website should you want to check out the presentations from those folks there. Let's go to the next slide. Great. So today is all about you. We're really excited to hear about your work and celebrate all of your successes from the last 9 months. We're here to share from each other, learn from each other, and hopefully stay connected after this process, and we'll share some ways you can stay engaged with the E-QIP team. If you are going to be tweeting today, I will be trying to tweet as well. If you could just tag us at #E-QIPON, and you can follow us on Twitter at E-QIP_ON. And we'll be promoting training through there and sharing some good QI goodness. Just go to the next slide. So when we get to your presentation, if you could introduce yourself as well as who's joined you from your team. This is an opportunity to just make sure that your audio is working. The slide deck will be circulated after our presentation today. I'll be doing a follow-up email that will include a link to the day 1 presentations as well as those slide decks. And during the presentations, if you could please mute yourself if you're not speaking, but if you do have a question, I believe one of the team members is monitoring the chat box. We're happy to answer the questions. If you could just type it in the chat, and we'll go over where that chat function is located in the next few slides. And as I mentioned, we'll be uploading the report backs to our YouTube channel as well as our website, so you can go back and reference them following the presentation. You just go to the next slide. Great. So I see that we don't have the Zoom slides in this deck, but if you wish to show your video, just click on the video icon at the bottom of your toolbar. It's on the left-hand side. The little phone icon is to control your mute or unmute. And on the right, you'll see a little thought bubble. Oh, there they are. And that is the chat function should you have a question. No Shabazz smirking at me. So that's an overview of Zoom. And with that, I'm going to pass it over to CMHA Middlesex. So take it away, Chris.
So I'm going to stop sharing, Chris.
All right. And I will see if I know how to do this.
At the bottom, there's a share screen icon. It's a little green box with an arrow. Yep, there you go.
Yeah, so you guys can all see? Sweet. Okay, so I'm Chris Babcock. I'm the Quality and Performance Improvement Officer and Privacy Officer at CMHA Elgin Middlesex. Our team members are Matt Wilson and Lorraine Fay, who were unable to attend today, but we do have Nadrita Shemshadini, Ashley McKenna, and Dina Stolfi with us, and they'll each have a section to present. So our project was improving participant involvement in decision-making about their support while in the transitional residential treatment facility. Go over here. Good. Our client story, basically CMHA Elgin Middlesex Transitional, I'm going to say RTF because it's quicker. Transitional RTF is an alternative to hospital. It's a transitional supportive housing program for individuals with mental health and or addictions concerns that are either referred to us from hospital or prior to preventing a hospitalization. So it's like an alternative to hospital, and it's 3 months flexibility and length of stay. And so we focused on question 12. And although our score for question 12 in the OPOC, which is I was involved as much as I wanted to be in decisions about my treatment, services, and supports, was good, we did notice that over the past 2 years, there's been a steady decrease in that weighted average score. And we also noted that there is a difference between how staff view success, meeting goals, and readiness for the participants compared to how participants and their family members perceive what that is. Our problem statement. So our group had a variety of perspectives and experiences, and we did struggle a little bit around coming up with a problem statement, but with the help of our E-QIP coaches, we did come up with, since 2018, during the discharge process, CMHA Middlesex TRTF program participants did not feel involved as much as they wanted to be in decisions about their treatment and support. This is also a problem because the disparity between staff perception of success, meeting goals, and readiness versus participant family caregiver perception does exist. And our aim statement is that CMHA Elgin Middlesex will improve the OPOC score for question 12. I was involved as much as I wanted to be in decisions about my treatment services and supports in the transitional RTF program by 2%, going from 3.47 to a 3.54 score by December 31st, 2020. And when we were looking at our aim, we looked at how it fit, and it does fit well within our organization. Our priorities, one of our strategic directions is to enhance the individual experience by supporting every individual who walks through our door to determine their recovery journey. And also in our 2020-2021 QIP, we have an objective that is to provide services that are driven by the participants and support them on their recovery journey. As for diagnostics, we did quite a few. So we used a variety. The root cause analysis that we chose was the fishbone. We also did 3 different 5 whys. And we wanted to drill down further with those. We realized we needed some more data, so we did an additional survey after our fishbone, and then we did a process map as well. So, and the process map was on the journey of the participant through the program, and we were looking at roles, tasks, responsibilities of what the participants have in the program and what the staff have in the program. And so now Nadrita is going to take over from me and walk through the fishbone and a 5 why.
Great, thanks, Chris. So the first tool we used was the fishbone. We came up with 5 categories, as you can see there: participants, the resident themselves, employees, our practices and procedures, and policy. We did note that some causes were interrelated, and you'll see that in the orange font, but they were a bigger picture for us to look at later. Although we had a lot of possible causes, we felt we needed more insight into the problem, meaning we needed more data. We felt involvement in decisions about your treatment and support could have various meanings for our participants. As a result, we created a brief survey, as Chris mentioned, for both participants in the program and staff to see if there was a common concept. As a group, we felt that we agreed under the practice we should look at no interim mid-stay check-in. So we completed a 5 why for that, which we'll get into in the next slide. So the no interim mid-stay check-in, this was a fairly easy exercise. The current practice was based on our OPOC implementation plan. It is the complete OPOC at the end of the stay. This was decided due to a shorter length of stay in the program, which is about around 3 months. From this, we felt a process map would be helpful to look at the participant's journey into and out of the residence. We also reviewed the OPOC implementation action plan and possible implement the OPOC prior to completion of the program and not at discharge. And the additional survey, we asked residents and staff, what does being involved in decisions about your care mean to you? There was little difference between residents that had been discharged and current residents. They felt that the question addressed their ability to have control over their recovery and to make informed decisions. They felt it meant that they could use their own voice and still have people advocate for them. And the additional staff survey, this we found quite interesting. The residents answered the actual question where staff looked for reasons why residents may feel they were not involved in decisions about their care. They went straight to problem solving. And so Ashley is going to follow up with you around the process map that we completed.
Thanks, Nadrita. So the next step that we did was we created completed a process map with all of the staff at the transitional RTF program during one of their staff meetings. And the plan was to complete an experience-based design survey once we had all the main steps in the process. And the slide's a little bit difficult to see, but I guess the most important thing to note is that all of this green squares that you see there are tasks and responsibilities that the resident is in control of or responsible for. And all of the blue squares are the tasks or responsibilities that staff are responsible for. So you can see by looking at this that staff take on a lot of the responsibility, and they were kind of surprised how much they were actually doing, and excited about looking at ways how they can move some of those responsibilities from themselves to the residents so that the residents could take more control and ownership of their treatment path. Next slide. So the process map, one of the things that came from the process map was there was a lot of work around orientation. And that was also something that came up in our fishbone diagram as well. So when we met again, we did another 5 why exercise around the orientation process. So this one was a little bit more complicated. And as you can see, we ended up with a couple of branches. So it wasn't as straightforward as we thought it was going to be. So some of the things that came out of it were the short-term nature of the program, categories such as health, safety, medication, and paper were all kind of equally valued and important to staff. And we also had a target that had been previously set by the agency of completing the orientation in 5 days. So some of the actions that came from this 5 why were we wanted to review the agency target of 5 days because we were wondering where that came from and if it had to be 5 days or if we could look at extending it. And we also wanted to review the orientation checklist and look at prioritizing different parts of the orientation and also emphasizing pieces where participants could be more involved in decisions about their care. So when we met to go through the change ideas after we did the change idea training in Toronto, we came up with 6 main change ideas. So the first one was to use the locus tool, which was a tool that the agency had been exploring previously, to make sure that all of the referrals that we got for clients to the program were actually a good fit for the program. We looked at adjusting the timeline for orientation process and to structure it based on priority. We looked at facilitating one-to-one or group education sessions with clients around goal setting and decision making so that they felt like they had the skills to be able to kind of take ownership of their own care. We wanted to increase IRP reviews and provide more options for self-assessments. We wanted to potentially look at increasing the length of stay for the TRTF program from 3 months to potentially longer. And then the last one was we wanted to make more of the orientation and assessment materials electronic, because one thing that we noticed was that we're having a younger demographic coming into that program. So we thought that might help to meet more of the younger demographic needs. So once we came up with our change ideas, we actually listed the steps to achieve each of those, and then we prioritized them as well to say which ones we thought were the most important and then which ones we might be able to look at implementing later on. So Dean is going to now talk about our project measures.
There. So our outcome measure was the percentage of participants that disagreed or strongly disagreed to the question number 12 in the OPOC, involvement in decisions about care. We had 4 measures. Training is actually scheduled, that 90% of full-time supportive housing staff are trained on locus, that 100% of info and brief support staff are trained on locus, and that the locus tool is implemented as a referral requirement for transitional supportive housing programs by September 1st, 2020. We chose OPOC question 30. The services I've received have helped me deal with more effectively with my life's challenges as a balancing measure, with a hypothesis that there would be no decline and possibly improvement as a result of the changes we implement. Okay. Oh, sorry. So the results and the highlights. We had 2 challenges that interfered with moving ahead with our change dates ideas. The team lead of the program left for a different position in our newly integrated agency. And like everyone else, we had COVID-19 come about. And that said, we did accomplish a couple of things before the pandemic. The subgroup volunteered to review the orientation process, and we did get a master's in public health student who's completing an environmental scan. Current state and lit review on assessment and screening tools. So they're working through that. The locus could be one of the tools recommended for the entire branch. As far as organizational enablers go, we went into the project and we felt the team and the staff attached to the program were aware of the QI approaches. This was not our first project for the agency. It offered some familiarity and was easily accepted by staff. And as we said in the previous slide, when the COVID-19 pandemic came to the forefront of work, we did across the agency in mid-March, it effectively put the QI project on hold. So we speculate that as we had to change how we provide services would obviously affect participant perception. Okay, so sustainability and next steps. We're basically continuing after our pandemic pause. You saw from the earlier slides that some of our goals and dates extend into the fall. Our organization will benefit from this presentation by showing other program managers in our presentation. They can see how the QI journey works and may be more willing to be involved in the future.
Okay, that's it. And I am the contact if anyone has any questions.
So thanks, Chris. So we'll open it up for questions now. Does anyone have any questions for the team from Middlesex?
Was that good?
It was a great presentation. Margot's got a
Margot
question.
Cameron has a question.
The actual Margot
Which
Cameron.
Margot?
Okay, so I was interested in something you said. Oh, apparently I have to turn up my speaker.
I can hear you.
You're good.
We've got a few of us social distancing in a room, so we're just trying to figure out the.
Margot, we can hear you.
Oh, you can hear me? Okay, great. So I was curious about what you said in the beginning, recognizing that sometimes staff and clients and families didn't have the same perceptions of recovery. And I don't know if you have explored the recovery philosophy framework and understanding of recovery. It's something we're just in baby steps in embarking on, but that might help to bring some continuity to how staff understand recovery and recognize it's from the client's perspective and not from our perspective. So what success may look like for us may be very different from what success may look like for clients.
Yeah.
One thing I have encountered is something called the Therapeutic Alliance, which is a psychometric tool that helps clients and their primary staff worker to evaluate their relationship and look at whether they're seeing goals the same way. And it's a tool that can be used on a regular basis to, like, say monthly, to just kind of check in and say, okay, are we on the same page? Do you understand me? Is the client feeling supported? So the short form for it is the BRWA, but it's called the Therapeutic Alliance tool. And I was introduced to it by Greenspace.
That's great. Thanks.
Other questions for the team? So I have a question. You guys have done E-QIP now for a number of years. You've been part of a few different cohorts. What did you do differently this year? Like, or did you do anything differently this year? And if you were to start again into cohort 5, what do you think is critical to success?
That's a good question. So out of our group, I'm the only one who has done the E-QIP training prior to this. So the approach that I took was, I started by looking at the OPOC data and deciding which program areas might want to be involved in a QI project. And I left it to them to choose. And so it was the transitional RTF manager who said, yes, I think we'd love to be involved in that. And our thought was, we want to expand some of that QI expertise throughout the agency, because me holding all of the cards is not helpful, and we want to have that knowledge spread. And so we chose the team based on having the team lead of the program, but also a director who is a director of several programs so that they can get that knowledge. We had Ashley from Elgin at the time. We were integrating, but not integrated. And we want to make sure that well, now that site has the expertise as well, and someone from another program area. So we really kind of had a blended team, which had both, and we had a peer support. And so it had its drawbacks because not everybody knew the program we ended up scoping on, but they do all now have that expertise. And I did not go to the trainings because I've had it, but I helped to kind of advise and coach and bring them through some of the tools. So I think it is, if you've done it once, I think it's a really good idea to have other people go, because the more people with knowledge, the more that quality culture is going to improve.
Yes,
and the more they're going to be really willing to take on projects, because even though right now we don't have the results that we want because of COVID, we will. And then we'll be able to visually display it. And then staff can go, oh, wow, that is so cool. Because I mean, everybody loves data and pictures. And then once you, once you do that, then they're going to want to do it again. And so we have people from different areas that now have some expertise to drive and run their own QI projects, and then they can use me to help them through it, and then they'll become an expert.
Absolutely. Thanks, Chris. That's a great explanation.
Yeah, and Chris, I had picked up the beginning of your presentation around the development of the problem statement and how you as a team were challenged to come to a consensus on what it was that you were, and I think part of your explanation to what Noshiba's question was kind of explains that, right? And so to that point, it's really important to have what you've done, considering your, all the different perspectives. It truly was about capacity building, but there is also value in making sure that you have the right people on the team, right, to be able to get to that consensus a little bit sooner. But good for you for working through that for your whole team, not just Chris, for the whole team. That's really well done.
Thanks.
So Margot's put the name of the tool in the chat, and what we'll do is we'll make sure that the chat's also transcribed and you'll be able to see that. But if people want the tool that Margot mentioned around Therapeutic Alliance, it's available there.
Great.
And if there are no other questions, we will move on to the Crossroads team. And Corey, are you good to share your screen?
I believe so. Just give me a moment here.
Yeah, it's the green icon at the bottom.
Perfect.
All right. I think we're good. Looks good on my end. Can everybody see that?
Yep.
We can.
Awesome. All right. So I'm Corey Fields, Program Manager at Crossroads Center here in Thunder Bay. With me today, I have Veronica Malinowski. She's one of our recovery facilitators. We do also have Mary Brown and Jan Adams. Unfortunately, neither of those individuals can be with us today. So it's just the two of us. So it's kind of indicative of our project team, where, to quote one of our previous coaches, the small and mighty team from Crossroads. I don't know how mighty we are now, but we are definitely small. So our project was basically charting a course towards a better post-treatment residency at Crossroads Center. So we initially had our executive sponsor suggest that we look at our transition process, as we had focused on, I believe it was question 26 or 27 on the OPOC, about how clients felt that we were offering a good transition phase. However, as it would come to our,
when we reviewed the data, we noticed two things. The first was that our data didn't support our current problem statement. And the second was that our data showed us that a very real concern that 1/3 of our clients were being involuntarily discharged by staff. So we decided to shift our focus and dive deeper into that, because as a team, we didn't think that was acceptable, and we wanted to try to help set our clients up for better success in our program.
So our problem statement had gone over a few revisions, because we actually had a problem statement for what we were doing for the OPOC prior to what our data would lead us towards. So our new problem statement, which again, like anybody else will be able to attest to, would have changed several times. So our current problem statement is that the current percentage of all client exits within Crossroads' post-treatment program are discharges by staff. Between April 2019 and January 2020, the staff discharges account for 35% of all exits in that time frame. And this is stressful for clients as they are left to the unknown, feeling unwanted or undeserving, and can far too easily end up as a relapse.
Corey, I'll just ask you to forward your slide deck. I'm not happening at your end, but we're not seeing your problem statement slide.
Oh,
We're just
okay.
seeing your title page, and it's not in presentation mode here at this end.
Okay.
What may need to happen too is click on enable editing. So it
Okay.
moves.
Oh, good point. Thanks.
Stop share.
Try sharing it again. That always happens when you change the, yeah.
There you go.
Okay.
Yeah.
Perfect.
Yep. There we go.
Okay.
Thanks, Corey.
One
Certainly.
client story now.
Yeah.
All right. So problem statements. So now we're at the aim statement. So our aim statement is that by November of 2021, Crossroads Center Incorporated will reduce post-treatment discharges by staff by 10% over a 2-year time frame, with the goal of reducing the stress for clients being left to the unknown, reducing their feelings of being unwanted or undeserving of aid, and to reduce the chances of post-treatment relapse. We felt this aligned with our values as an organization, as it will foster better accountability, resilience, and excellence with our clients. So for diagnostics, we have the fishbone diagram, which there's a lot to it. Whoops. There we go. So we have procedures and processes, providers, persons, clients, policies, place and equipment. Now for procedures and processes, would you like to read what's in there?
We thought that maybe our programming wasn't robust enough for clients, and perhaps that was why they were getting bored of breaking the rules. We thought maybe a lack of structure might have been a problem. Problems with goals or connecting with counseling outside, because we don't do counseling in the center anymore. We outsource it. Staff shifts can make it really difficult for especially the recovery facilitators to have connection with their clients, because they're often on site or off site or in programming. The intake process has changed. We've had a lot of changes over the last little while with our programming, and there's a lot of how it used to be and how it is now, and a lot of crossover where there's lots of confusion with our rules or even our programming with how it's running right now, for both staff and client perspective, which is never a great thing.
And then for providers, we have, for us, we don't have, for our programming, there's no service completion date in Thunder Bay, and I'm sure that this is everywhere, that there is a housing crisis. So maybe when the opportunity arises for somebody to find lodging, they just stop caring about what's happening, and then that will transition into breaking of rules. There's no system to track service completion, so again that'll lead into the procedures and processes where they don't attend our programming anymore, get bored, and then start breaking rules. Lack of more intensive part of programming for goal planning, providing service while clients are actively working on goals. Clients may be good influence on other residents and inspire new people, but sometimes there is the reverse of that. The recovery facilitator workload is substantial enough that some of the veterans, those that have been with us for a while, kind of get lost in the shuffle, again, relating back to insufficient one-on-one time with everybody. Admissions, discharges can be more intensive. Clients are prioritized. Supervision needs to happen in some cases through the admission or discharge process. And when that happens, unfortunately, sometimes some people, clients will just have free will and they will make some choices that may not necessarily, or I should say, will conflict with our terms of residency. And down in, sorry for the pauses, I have to keep moving the bar. So for, say, policies, there's no statement or timeframes, guidelines that say you can only be here at Crossroads for X amount of time. So that does correlate to people staying longer than they may need to, or shorter than they would like to. And in either of those categories, again, they will make some choices that will conflict with some of our terms of residency, and then with consistency or inconsistency through the rest of our policies. Basically, like, people will slip through the cracks or have to be discharged by staff. As long as required, necessary for clients to make progress to identify goals. Sometimes people will just stop working on their goals. There's a lot of different factors that come out as we were going through all of the 5 H's, or 5 W's, 2 H's, doing the fishbone. And I mean, this fishbone is really just a quick snapshot. And it's funny to say quick snapshot given all the information that's here, that really break down into why an individual may end up being discharged from our center. And although some of these may sound positive, the effect that it has on any particular client on any given day can be perceived by that individual as a negative. So a lot of what we've come across and have a far better understanding of is just how important it is to understand a client's perception and their feelings about what's happening around them. We devised a process map to kind of show us people coming into the center and then hopefully transitioning out. So as you can see, there are multiple areas where a client can be exited through different choices that they may make. And that honestly does stem from, as you can see here, right from the admission. They may make a choice or two that might result in being exited. Directly after orientation, through the first couple of days, not having a solid understanding of the rules or not exactly wanting to operate under the rules that we have, through when they're actually attending programming, and then even into the active recovery and transition goal process. It was difficult to just lock down like those 4 areas, because honestly, again, how an individual perceives the level of care that they are receiving can become a very negative thing, and then that will impact how they follow rules and at what stage in our process post-treatment that they may have to be exited by staff.
Uh,
This is Veronica.
Yeah. So we decided we need to dive a little bit deeper to find the root causes that we actually need to work on. As you could tell from our fishbone, we had way too many ideas and really needed to narrow it down. So we decided to, well, I just devised a survey. I looked at our fishbone and noticed that there were some themes that kind of came out. I believe there's 10. So there was about 10. So I devised a survey both for staff and our clients to complete, to see what they thought needed to be improved upon. So one-on-one time with the recovery facilitator was definitely one of the top ones, and rule enforcement. So like whether or not our rules are being enforced consistently across our entire team. Both clients and staff really felt that it wasn't very consistent, which is definitely not good, especially when it comes to staff terminations, because if we're not giving consistent messages, then they may not know they're breaking the rule when they actually are, and it can lead to a staff discharge. And the recovery facilitator position was another one, but we decided to focus mostly on the one-on-one time and the rule enforcement for this particular project. So our change ideas, the first was to update all relevant documentation regarding policies and rules, including all of our terms of residency, any of our operations manuals, anything that covers our rules, to make sure it was all the same consistent message. This would be impacting the staff and the clients. And the idea is that there's inconsistently currently, like I said earlier, we are in a huge transition phase right now from what our program used to be into what it is, and our documentation doesn't really reflect that right now. Some parts of it do and some parts of it don't. So that was definitely something we wanted to tackle. So if we have a consistent message that's in both of our training manuals and in our client rule book and stuff, then we can enforce them more consistently and clients know what to expect. And the idea we'll see if the changes are working is when clients start to receive less redirection based on the rules. Like we don't have to tell them their rules consistently as much anymore. That's the hope.
Oh. Sorry.
The next one was to provide a comprehensive training for all staff, and to have a meeting with the clients themselves regarding the updates to all of the rules to make sure everyone's on the same page. And then Corey decided that we should alter the recovery facilitator shift rotation in hopes that it will allow us to meet with our clients one-on-one more frequently.
Oh, I guess it didn't. All right, well, we had some. So for our measures, percentage of post-treatment discharges with the exit disposition, discharged by staff involuntarily with referral. The process measure, well, clients begin to receive less redirections, and hopefully that has a far-reaching positive feel for them, so that they actually feel that they are deserving to be here, that it has a definite positive impact. Now, unfortunately, it didn't save, but I did have in the balancing measures that it does actually have a negative impact on the pre-treatment clientele because of, sorry? Or it could, I should say. It could have a negative impact on the pre-treatment clientele because we would, as a team, be far more consistent in our rules, and people who do come to us as pre-treatment are very new to recovery, and therefore following the rules that we do have can be a lot more tricky for them. So it can result in a lot more pre-treatment discharges by staff, while we reduce the number of post-treatment discharges by staff, just in that being consistent in the rule enforcement.
Pre-treatment clients also tend to be more unstable and coming from 0 rules, whereas like post-treatment's coming from, you know, a 28-day intensive program where they have intensive rules. So it can be a little bit jarring for them, for pre-treatment clients to enter our center with all these rules after living life how they wanted to, which can, for consistent rule enforcement can definitely result in more terminations.
I didn't say anything. So I had actually kind of jazzed up our run chart a little bit, but just like the last slide, it didn't save that either. So as you can see, the from April of 2019 through, we'll say at least December of 2019, that there was quite the positive numbers for post-treatment discharges by staff. Into January, it did dip, which was great. And then from January to February, it went down even further. Now, when you see basically the giant rise up to the 2% in March, that is basically when we had actually instituted some COVID-19 pandemic protocols for the center. And one of those is basically putting the center, the individuals at risk for safety, their health. And as you can see, there were a few people who made some poor choices. However, that is only because of the pandemic. So we're really hoping that going forward, that it would continue to decline, as you can see between March and April, where people were far more consistent in the understanding of what the rules are and how serious they should be taking the COVID-19 pandemic, because we do have a live-in recovery home, or we are, I should say, our live-in recovery home. So any decisions that they may make do not just impact themselves anymore, it impacts everybody in the center. So around between March and April, that's where we actually started getting very consistent with our rule enforcement, being consistent, and we had actually also implemented the recovery facilitator shift change. So now we have 2 people. It's kind of a weird setup now, where we have 2 people during the day, starting at 8 and 9 respectively. 1 person starting at 11:30 every day, and then 1 person working basically 4:30 till 12. So that we are trying to have a recovery facilitator on at all times to cover all hours of the day, so that they have the opportunity to meet with their clientele, address any potential concerns or crises that they may be having, and
we rotate those shifts. Like, so each week we work a different schedule, so it allows each of us to have each of those different time frames to meet with our clients. Corey also made it so the 11:30 to 7 would be running actual programming to really open up our schedule to meet with clients, and I think it's doing okay.
So far, we don't have any data to back it up.
We've only been through like 1.5 cycles of this, or maybe almost 2 cycles of the schedule, so it's still a little unclear as to how it's working.
It's actually only 1.5.
Oh, really?
It hasn't really been that long. It feels a lot longer.
It does.
However, we do plan to survey our clients to see how they feel about how the schedule is working, so that they can actually have that one-on-one time and see how much of an impact it's having on them, because at the end of the day, that's what matters, is how any changes are hopefully having, sorry, let me rephrase this. Hopefully all the changes that we have implemented are having a positive effect on them. So,
It didn't save anything on that slide. We finished this all yesterday, and it didn't save any of the work we did.
I can almost cry right now. So
You're doing a great job, Corey. Don't worry.
Thanks. So what we did actually have here was one of the major data highlights was just how you might start off trying to formulate a problem statement, an aim statement off the OPOC to begin with. But when you do submit the data, and to this point, thank you, Abel, so much for helping us with the data. The data can completely change what it is that you're going to be doing, how you're going to go about doing it. The data cannot just be informed by what you're doing, but it could completely inform what you are doing. Because we had done probably a solid month's work on our previous problem statement. And then when we submitted the data, it was quite obvious we didn't have the data to back that up. But we did come across the fact that a third of our clientele were being exited by staff, and that just seemed completely ridiculous to us. So to everybody else out there, just keep in mind, don't be afraid of the data. If it doesn't back up what you're going for, you know, just trust your team, trust the numbers, trust the data, because it's better to have the data to back something up as opposed to trying to plunge forward without the data to back you up. So that was also kind of our experience at Insights as well. We had it written down, but unfortunately, apparently my computer didn't like me yesterday. So yeah, our results were strongly affected by the COVID-19 pandemic and the protocols we had to put in place for it. Just like all the rest of you, our project had to take a side seat when the nation, the world was hit with the pandemic. And I just want to say to everyone, kudos to all of you for still being able to carve out any time to still do this, given that I'm sure, just like us, you have had to implement QI on the fly almost daily. Didn't save this either.
No, nothing.
All right, so basically I have it saved somewhere, I hope. But basically it's going to come down to, we still have a lot to do, to work on. Our data is incomplete. I mean, it's only been a couple of months, and for what we're trying to do, it's really no end game. It's going to be consistent, it's going to be ongoing. And that's part of the reason why we chose a 2-year time frame, so that we do have the ability to implement some far-reaching changes if necessary. And it also helps with when we're onboarding new staff during that time frame, that we can get everybody on the same page. And something else that we're looking at doing is actually creating sort of like a slideshow for new training, so that we can have a visual component to our training as well, to help others who may not necessarily learn by just reading or being told stuff. And then we believe that every department in our organization will absolutely benefit from the E-QIP tools, because it just helps in so many ways that honestly our cook and our maintenance person could benefit in order to help like be far more effective and productive in day-to-day operations. And that's it. So I'm the contact, again, Corey Fields, program manager here at Crossroads. By all means, if you have any questions, give me a call. I'm always happy to answer what I can when I can.
Thanks, Corey. That was a great presentation. And if you find the slide deck with the updated stuff, send it to us.
I absolutely will. And if I don't, I'll just redo it and send it anyway.
Well, don't kill yourself to redo it. Hopefully, hopefully you just find it somewhere. So I'm going to open it up for questions at this point.
Corey, it's Debbie. Was really pleased to see how you had in your change ideas. You had talked about how clients are reducing the redirection for clients. Just wondering about how you'll measure that. Is it a chart audit or some way you're recording that?
We honestly haven't figured out exactly how we're going to record that yet.
I do know that in EMHware, there is an option to address a contact note as a redirection or contract. So maybe there's some way we can look at that data, pull that. But like Corey said, we haven't figured out exactly how we're going to do that yet.
Yeah, super. Yeah, it's nice to see that, because it's an important factor for your work.
Absolutely.
Yeah.
Other questions for Corey or Veronica? So I will pause, but I do have questions. So I will take the opportunity to ask some questions. So you guys had some, I mean, I know you didn't have your full list of measures. I'm wondering about balancing measures around staff satisfaction, because you're making changes, especially the shift change. I know you were mentioning that. I'm wondering if that's potentially a good balancing measure to consider, and whether you've actually had, like, how staff, I know you said you've only been through a cycle and a half of this at this point, but have you had any concerns raised from staff?
So yes, a concern that we had, and again, this plays into the whole sort of QI on the fly bit, was the 11:30 to 7 shift that was created. A lot of the feedback that I've recently received was that some of our recovery facilitators weren't feeling like they were actually being given the opportunity to meet with clients, because we are still in operation. We never closed our doors. We have still been taking people in. So we have a couple of isolation rooms where people have to stay for a bit before being allowed into basically general population, depending on which end they go in. So because we could have anywhere between 1 to 3 people in self-isolation for upwards of now 7 days, but at the beginning, it was the full 14 days. So during those timeframes, a lot of the recovery facilitators were taking on extra responsibilities, including running programming. So they didn't really feel like they had that opportunity. So since we met and discussed it, I made the call to make it so that that shift does not run any programming, to take one extra thing away to get them to where I was hoping to get them in the first place. And that's only been this week.
Yeah, I'm actually the one that's working that shift for the first time without running programming, and I've definitely been able to meet with my clients much easier. I met with 3 yesterday alone, so.
That's great. And I guess maybe like what you're kind of flagging, it sounds like, is some of the issues within the COVID environment, that things are quite different in the way you deliver. So I guess you're gonna have to keep an eye on it when you start opening up. Yeah.
Yeah.
Yeah. Like I said, we never closed our doors. We've been open this entire time. I mean, it might sound kind of, I don't even know the exact word, but it sounds weird when I say it all the time, but we have legitimately been doing QI on the fly almost daily.
Well, I think everyone has, and it's great to have it called out that way.
And I'm just thinking about, Corey, we have a great job on the presentation considering that you had some of your slides weren't saved. So I really appreciate that you were able to approach that with humor and keep that going. That was really great. But I was just thinking about one of the upcoming presentations from Renaissance. It would be interesting for you to hear that presentation as well and some of the QI that they've been doing for their programming. I feel there's some connection or some likeness there. So I'm so glad that the two of you signed up for the same day, because I think that'd be really great to hear. Mm-hmm.
Awesome. Look forward to their presentation.
Mm-hmm.
So other comments or questions for Corey or Veronica?
Just one comment I had, I really like the connection that you made to your organizational values, because I find often the values are just people create value statements and they kind of don't go anywhere after that. But I really loved how you connected that, okay, if we make these improvements, it's more consistent with, you know, the way we do business. So I really like seeing that.
Thank you very much.
All right, Corey, I'm going to ask you to stop sharing your screen and I'll start sharing mine to show Windsor Essex next up. All right, so is everyone seeing my screen? No. Now are you seeing my screen? Yeah, all right. So I will turn it over to the team from Windsor Essex.
All righty, thank you very much. And we're absolutely delighted to be able to report back about our Excellence and Quality Improvement initiative and the results of all your hard work in coaching us. So I think you can move to the next slide.
Oh, I'm not sure.
Okay. So this is just called the Case Management Staff Orientation. And as you can see, we have a representation of staff from across the organization. I actually got 16 volunteers when I first sent out a request of interest in quality improvement. And so we selected staff from across the organization, and they represent a whole variety of programs, everything from therapy to CTO and early intervention psychosis. And then the focus really narrowed down over the course of our project to case management staff, which is the largest bulk of staff that we've got. So where did this story start? The journey began a year ago with a chance conversation I had with Carrie Davis as she's doing her master's at Waterloo in social work, but in an interesting stream related to healthcare. And she was telling me about a paper she was writing on a staff-led orientation initiative. And orientation was one of the things that under my role as clinical practice specialist, I was tasked at evaluating and considering making some changes about. So this paper that Carrie was writing, I said, you know, when you're done, can I read it? So I did. And was very impressed with it. And basically the literature indicates that in the field of social work, there's not a lot of robust orientation that's done when individuals take on new roles. And Carrie's group project approach was looking at a staff-led orientation initiative. And so that's what I wanted to do, was engage staff. So I asked Carrie if she would co-chair the committee. I heard about the E-QIP opportunity for proposals. So I wrote that up and went to my boss for the 2-minute elevator pitch. And because she was already a pro herself in terms of quality improvement and very engaged about it, she was excited. And then I approached Evelina Horchowik, who was another keen staff who I knew had a passion about quality improvement, and she agreed to co-chair it. And that's how we got started. So I'll turn it now over to Carrie, and she'll
Carrie, can you just let me know, are my slides advancing? Yeah.
No. You have
No,
to
yet?
take down your,
Is it problem statement now?
yes.
Okay, perfect. Thanks.
Can you, oh, you got it? So our problem statement is, since 2007, clients in intensive case management ICM program receive variable services from diverse ICM staff to meet their similar life challenges. This variability in services means some clients receive excellent evidence-based services and other clients receive care that is delivered to the best ability of the staff that may not be evidence-based or the current standard of excellence in mental health and addictions field. As determined by OPAC question number 30, only 51% of our clients strongly agreed that the services that they receive has helped them. Help them deal, okay, can you go back? Has helped them deal more effectively with their life challenges. Currently, 0% of the 25 general ICM staff identify that there is a defined standard of care within case management services at CMHA Windsor Essex. Then, okay, so our aim statement is that by December 31st, 2020, we aim to have 75% of clients strongly agree that the services they receive will help them deal more effectively with their life challenges. And 75% of the ICM staff will identify that there is a defined standard of care within case management. And this will be achieved by developing a standardized clinical orientation process. Next. And so we used a number of diagnostic tools, and this one was used a little bit later on. We did a process map, and so this is what it looked like in the raw form, and then we presented it to the ICM staff and then had them list the tasks that they do at each interval of meeting the client. So when their client is assigned contact, first appointment, or if they're unable to contact. And we looked at variabilities of the information that they had given us and similarities as well. And we presented that information to our CFAC committee, which is our Client and Family Advisory Council, and gained input from them as well. Next slide. This is another diagnostic tool that we used, our fishbone. So like everybody else, we looked at the client staff policies, place and equipment, and processes. So we took probably about 15 of those ideas that we thought that we agreed were probably most likely could be root causes to what was contributing to our problem. And then from there, can you switch the slide, please? We created our Pareto chart. Evelina sent that out with 15 questions. So I took those 15 root causes and we received 38 staff responses. And we asked them to rank the top 4 statements that they believed were accurate. Next slide. So this is just showing the frequency count, and you can see that there is there's some areas that show a higher frequency than others. But on the next slide, it'll show the top 4. So the top 4 answers for us were lack of standard and comprehensive orientation for new case management staff. And then the second one was lack of defined standard of care at the agency related to case management. Number 3, case managers lack a clear understanding of their role and expectations. And 4, case management services delivered to clients vary depending on the case manager. So from those, we went to the next slide. We started developing our driver diagram with all these change ideas. We had a big group on our committee or our team, and they were very motivated and driven, and we came up with many change ideas. But upon reflecting on some of the data, we chose to narrow it down to one area. So Evelina, I'm going to pass it on to her.
So next slide, please. So this is a more specific driver diagram to focus on one of our change ideas or kind of implement a standard process. We noticed that secondary driver would be a lack of orientation, and also case managers not necessarily having a clear understanding of their expectations and roles. So we wanted to focus on implementing a standardized orientation process and training for current staff that maybe are transitioning from another role to case management again, or if they were on a leave, or any new staff that are coming into the agency into a community support work role. And we're hoping that the outcome would be that the staff would identify after we do a post-survey that they will identify eventually that there is a standard of care with management through this orientation process, because those role expectations would be outlined very thoroughly in our orientation matrix, which is kind of what we focused on doing. And next slide. So that was our change idea. That's what we wanted to test. So who was involved in our change idea? It was the community support worker staff members, a staff mentor. The E-QIP committee compiled all of the information, and we had a buy-in from not only feedback from management, but our leadership staff and other people on the committee who are in all different types of programs at the agency. And we also included a member from HR who was able to provide background from that component, which we noticed we were missing. So we started an orientation matrix for the staff member, and there was comprehensive information about the role, about the procedures required in terms of HR or administrative aspects, documentation, trainings, and anything that staff member might be expected to do in their role. And it also discussed how to do those things, who to speak to if you need additional assistance, and where to find information, because we do have like an intranet, we do have an EMR system that's separate. So all that information was outlined, and I'd like to share, which is, it's not included here, but at the end, I'd like to share my screen to show everyone what that orientation matrix looks like right now. So how do you know that there will be an improvement? So there are specific questions which I'll outline in the next slide about feedback from the staff member to ensure that it is useful. There will be a checklist. And also we will look at survey results to do a post-survey with staff. We're going to address and show the orientation matrix again at another mental health services meeting to show staff what it entails, get their feedback again. And also we're going to present it to the CFAT committee again once that's complete. Well, it is completed, but that's kind of our next steps to do. And our risky assumptions is that we're assuming we're providing the most accurate, up-to-date information, because there are a lot of changes that occur, but we are assuming that our information is accurate at this time and point. So next slide. Oh, it's on? So this is just showing our data items for the PDSA for our change idea. So when a staff member and a mentor are going through the orientation matrix, we'd like to keep certain questions in mind. So was the checklist easy to follow? Has it helped you complete your orientation experience? Are they benefiting from it? And would it improve? Would they like to see improvements to the type of format that it's in? And any other further suggestions that they might have. So we did a pilot with this orientation matrix with one case management staff and one mentor, and they had provided us feedback and information based on their experience. And we did notice we have to make some changes for our next PDSA in terms of how much time they might require, what feedback in terms of the formatting or the orientation matrix, and some information that it wasn't unclear in terms of frequency of completing certain items. Next slide. So here are our measures. Obviously, as mentioned in our aim and problem statement, that we would like to see the OPOC data of number 30, which is the clients being able to deal with life challenges. And we're also thinking that it might impact certain other questions in terms of maybe the frequency of how long the person's in service, maybe the discharge, being able to provide a good discharge plan, because knowing other services that are out there as well. The qualitative data would be client interviews, getting feedback from the CFAT committee, and also that pre-post survey for ICM staff. And the defining measures would be the developing that standardized orientation matrix checklist and rating that checklist usage. And we're going to be able to do that once it's implemented because our HR team is on board and they'll be keeping track of who's completing that orientation matrix with their regular HR package of orientation as well. And our defining measures would be change in staff satisfaction, that staff survey, changing client satisfaction, looking at the OPOC scores, possibly a length of service change, and the goal completion of the OCAN and engagement to reach goals. Next slide, please. So data highlights, since we only did a pilot with one staff, I'm going to talk about some of our implementation plans moving forward. So that's going to highlight our progress in the future because we do not have a good data set right now because we have not rolled out the complete orientation just yet. Next slide. Wanted to really focus on the fact that organizational enablers have a huge impact on our ability to do this project. Very dependent on them and also on the E-QIP team who has been very supportive in being able to train us and have all of us a big committee of so many staff and so many backgrounds and providing that training, and our agency's commitment to provide us with time to be able to work on this. And we met weekly, so that was a huge time commitment for the agency. So like I mentioned, on all staff levels through staff management, coaching, and supports. Next slide. This was our integrated data QI sustainability pre and post survey. So as you may be able to see, there are some reds when we did it in December, especially under quality and sustainability. And I think, and there has been some improvements. And if you could click on the next slide. The majority of those improvements, as you can see, it's because we have a lot of buy-in through our organization, a lot of support and leadership, and also the support of our committee members and their commitment to the project. And when we started, we didn't see, you know, the end phase. We were learning so much as a team about quality improvements, and we started just doing like the QI on the fly, like it was happening all the time, but we weren't recognizing it until later. And then also that buy-in from management, from HR, from our leadership has been huge in terms of our post-assessment and ensuring that we have those enablers to allow this project to happen and to continue. Next slide. So our next steps, in terms of the orientation matrix, we have to look at the formatting, add any missing items that we haven't had, and that's based on the feedback we received from the staff member and the mentor that completed the first time. And the reason we didn't want to roll it out in terms of a larger scale is because we wanted to do a small change and didn't want to impact you know, the staff and the mentors and management on a very higher level in terms of putting too much weight on their already very busy schedules and time. So that's why we wanted to do a small rollout, and that's why I wanted to do a rollout of mandatory components for our intensive case management staff, which is one of our programs, but we also have other programs that are specialized. So we have to also get some clarity from management on the frequency of certain items because that was a little bit unclear, and maybe color coding our mandatory components versus components that are more specific to other programs. Next slide. So in terms of our content, we have to check our risky assumptions and advise with managers, ensuring that our data is accurate and our information is accurate that we're providing to staff for this orientation and our mentors as well. Our committee and working group next steps would be to decide our frequency of meetings and reevaluate rules. It has been a huge time commitment, so just to see if everyone, whether we're going to do bi-weekly meetings, what our next steps are, planning, and developing the orientation matrix specific to specialized programs at the agency. And the rollout would be to present our matrix at the mental health service meeting to the ICM community support workers and the manager, develop a list of mentors for every program. And hopefully in the fall, we're going to start to develop the other programs. And we would like to, after we present at the mental health service meeting, roll out the staff orientation for any new intensive case management staff or any staff that would like to be have a tune up in terms of orientation that would be interested in doing that. Next slide. So who would benefit from the learning? I think I know Margot has been excellent in sharing information to leadership that we've been working on. It's been staff are getting updates at our team meetings. So everyone's kind of aware of what's happening, and they're able to ask and contact us to ask questions. So I think on all levels of the organization, this would be a benefit because it provides a bit of a structured, standardized process for and outline some of the expectations and guidelines in our roles. Next slide. And if anybody would like to contact us at CMHA WCB, please contact Margot. She's our clinical practice specialist. And if it's okay, I'd like to just share my screen to show you what's.
Yep, I'm gonna just stop sharing now, Yelena.
Okay, perfect. So can everyone see my screen? Guys, can you see that? Okay.
Yep.
Okay, so I know right now it's in an Excel file of the matrix. We're hoping maybe to change it into a Word and then it'd be printed off or make it a digital way to just click on something. It would take you to the right part of it. But right now it's pretty straightforward in terms of different sections. So this is all related to administration. Who would be the person to speak with, or what departments? How to do something like getting coverage, how to access certain parts of our intranet, sick call process, and then resources are policies and procedures related to each section, and any other link that would be useful to getting more information about that process. And when do you do it? So hopefully the staff is able to learn about this on the first day, maybe after the first week. We still want to make some changes because we realize even going through this orientation matrix takes a lot of time. And then the frequency in terms of when to redo this or get a refresher, we have like whether it's annually as needed once or when required, right? So that we have forms and requests, so like mileage forms, how to scan and print, IT services, tickets, documentation in terms of our EMR, how to do certain things in the EMR. And then you have links and then training videos, because we have some that our data support analysts has already prepared. How to do informed consents, where to find those, discharge summaries, referral forms, external referrals, internal referrals, the OCAN, introduction to programs, who to speak with, information sharing, the fact that we have team meetings, when those are, how often, health and safety, training and certificates, and then how often those might happen, because there are certain trainings that would have to occur. And with the buy-in with HR, they keep track of who's trained when. So this would be part of maintaining the sustainability of keeping this up to date. And that's who would kind of be responsible in terms of our supports, ensuring that we're updating this, but also that they're updating it as well, and ensuring all the changes are made and kept up. So that's about it. Thank you.
So thank you very much for from the team to the team from Windsor Essex. That's a great presentation, lots of detail. And so just going to open it up for questions.
I have one question. Thank you very much, team, for sharing how your senior leadership supports QI in your organization. I'm just wondering also, how has E-QIP and being part of E-QIP enhanced the QI culture or capacity of, in your organization?
You're on mute. Oh.
So can you hear me now?
Yeah.
Yes, we can.
Thank you for that question. So this project was the second one that we've had the privilege to do with E-QIP, and a number of staff had been able to, because our leadership is so pro quality improvement, E-QIP had been invited to come and do the leads training. So I would say the majority of the team members who volunteered and participated have had the leads training. And that was one of the things that made them excited and enthused about actually getting a chance to put it into practice.
That's great.
Did that answer your question, Linda?
Yes, thank you, Margot.
Can I ask a question? And so not to presuppose that you will be putting in a cohort application for cohort 5, but do you see extending this to other program areas? Because I think you said this is like, looking at what you put together, it's very extensive. And looks like it would go well beyond the intensive case management, but do you see needing to customize it for other programs? And maybe that's something for your next project.
Well, that's what will you shut off your mic? Okay, so that's what we're looking at. So first we were going to narrow it down with ICM, and then we're going to take it into different programs. So we have representatives from each of our programs on our team. So we have therapists and concurrent disorders and early intervention and youth case management, and I don't know if I'm missing anybody on the team, but yeah, that's what we're going to do. And we thought that we were going to color code it. So for next steps, we're color coding which area fits in for each. So there's going to be some training that is across the board for everybody, but there's also going to be program specific training. So just for ICM, or maybe for a therapist, or maybe for bereavement, or at the CCHC or CMHA, we just changed our name for our city center, our healthcare center, CMHA Healthcare. If you work there, you'll have some different orientation practices than some of the case management folks.
It
sounds great.
Yeah, and some great work here. One of the things I was intrigued with, because we also have a program at CMHA Brand Hold'em in Norfolk, is that frustration or the lack of updating of case management guidelines, and whether or not that impacts and sort of your thinking around how to manage that, especially around the orientation piece, because they've not been updated in a long time.
So we put in part of our next steps as well is that it would be a standing agenda item on the labor or the management committee. So they would discuss it quite frequently, and we're doing ongoing meetings. So it's not going to just drop off. We'll continue to meet to make sure that we're updating changes, and it will be discussed at the management level as well. So those changes will be implemented into our matrix.
Into the orientation as well?
Yes.
Beautiful. Yeah, I that connection with Brant Hold'em in Norfolk.
Sure.
I was also just going to say that from my clinical practice perspective, I think we did a really great job with the orientation, but I still think we need to have more standardization of care pathways for clients. So that would be an area where I feel like a QI could be done that would really bring some quality improvement to the customer service or the client services part of things.
Yeah, it feels as though there's a potential ABD, experience-based co-design opportunity here. And we just happen to be doing a presentation on that on Tuesday, a how-to do that virtually. So you'll be getting that information in your, when Ash sends out the slides for this as well for later today. Because it's a great way to get client feedback and dig it a little deeper.
All right, any other questions for the team from Windsor Essex? Okay, seeing that, I'm gonna turn it over to Michael and the team from Renaissance if you want to start sharing your screen.
Sure. Hello, everybody. I'm Mike Loughran. I'm the Director of Programs at Renaissance. And I'm going to hold off on sharing my screen so I can see my team. So on the call from my team, we actually have Alex Mata, John Bushell, Martha Williams, and Gail Power, who wasn't on our team, but is the program manager of our Monroe Center, which is where we were going to implement first. So. So our project is very cleverly called the residential completion rate. It's super simple. And so Renaissance operates intensive residential addiction treatment programs, center lengths of stay of 28 to 35 and 42 days. And there are many reasons why a client would leave treatment early. Some of them are preventable and some of them are not. However, every time a client leaves program, it's an indication something's changed since the decision to enter treatment. Often this is due to a crisis of some kind, which puts the client at risk of negative outcome. Without support, and our most effective means of support as a residential provider is to find a way to keep our clients in treatment. We do also offer referrals as part of our care pathway, and we try to support our clients in that way and get them re-engaged. But we wanted to focus on treatment retention. Can everyone see my screen? Yeah, okay. So our problem statement, the Renaissance Residential Treatment Program experiences clients leaving program before completion at a rate of 20%. This results in sudden diminished access to external and internal supports, often at the time of a crisis. At a time of crisis, this presents a heightened risk of negative impact on client safety, the client community remaining in program, and our counseling team. And we used a total number. So some of these would be for medical transfers, like basically anybody who didn't complete program, we included in that for whatever reason. Our aim statement, we will increase the completion rate of our intensive inpatient program to 90% by March 30th, 2021. And improving client experience is in many forms in all of our strategic and annual planning goals. It mentioned like quite a number of times, and program retention is an excellent measure of meeting client needs in a supportive, empowering way. So we used a number of diagnostics and some that we just kind of created as group activities, and I'm going to show you those. We did do some fishbone diagrams, and we did 5 whys. We did a driver diagram, and a lot of our data came from counselor-generated qualitative reports from early discharges. And what we found through all of this was preventable early discharges kind of fell into 3 categories. So one would be a lack of therapeutic alliance with peers in the client community. One would be a lack of therapeutic alliance with the treatment team. And one was found to be treatment fatigue near the end of program. And this includes we didn't differentiate between early discharges, like terminations by staff, or self-discharges, because a lot of them were actually found to have the same underlying factors. So our driver diagram kind of looked like this. So we found 3 areas, 3 different areas actually. One of them was substance use, with us being an abstinence-based treatment program. And we do a re-engagement process if somebody does use in treatment. However, they do end up needing to leave treatment, usually referred to withdrawal management, and then find a way back in. Difficult transitions into treatment and treatment fatigue. And for substance use, we found kind of 2 drivers. One was that clients didn't feel comfortable disclosing cravings to use, either with peers or with the treatment members of the treatment team. The other was the clients made a decision to use and didn't, and a decision to not disclose that. As far as difficult transitions, part of that was there's no scheduled individual activities in the first 7 days. The other part was they haven't developed supportive relationships, and treatment fatigue was found that we didn't have standard progression of work after day 14. And this relates to the Renaissance program is based in a very organic way, and we allow clients to kind of connect with counselors in an informal way. They can schedule one-on-ones whenever they would like to. They do have regularly scheduled recovery planning sessions, but a lot of our focus is on trying to allow very client-centered care, at which we completely stand behind at all times. But what we have noticed is that sometimes if you have a client who's withdrawn or fails to connect with a counselor really closely, they can get missed because we don't have that scheduled. Group sessions can be repetitive, and sometimes clients feel that they have all the necessary tools that they came to treatment for a week or 2 weeks before they finish treatment. So we actually came up with 4 change ideas, 3 of which we decided that we were going to try. So one of them would be the peer leader, and I'll explain them a little bit later on one of the later slides. So we decided to try to introduce one of our admitting clients to a client who's completing treatment as a peer leader or a peer helper, to try to help our clients like transition into the client community a little faster. We were going to have a scheduled staff check-in with clients 3 days into treatment, which would be something that is scheduled, but then also not a part of the normal recovery planning process. So it would just be a rapport building kind of interview. The third was to institute progressive treatment planning past 14 days. We have progressive treatment planning going up to 14 days. However, the kind of expectation is that counselors will then continue to develop individualized treatment planning and recovery goals with the clients. However, we wanted to have a baseline as well, like I said, so that sometimes clients do get missed. The other one we had was progressive group cohorts, which logistically would take a lot more work than the first 3. And I didn't put any of our fishbone diagrams on, but this is like an example of what our whiteboard looked like in the basement when we would be working on this. I really like this one because the little picture that you see is actually our representation of a client who's not engaged in group. So we used a lot of these and then translated them into either fishbones or 5 whys. So our change ideas, like I said, the first one was to introduce each client to a senior client or peer helper at admission program. And this may increase therapeutic alliance with client community and provide support in times of crisis. And this was actually found to relate to both discharges by staff and self-discharges. Because when we really discussed discharges by staff, you know, the behaviors that contributed to the process of this happening seemed to be an increase in stress that they couldn't process as well. And so it was kind of a maladaptive coping strategy to a earlier problem. So we're trying to address that. The other side of that was to schedule the rapport building individual therapy session with a counselor on day 3 of program.
Okay, I'm back on. Are you going back here? Yeah.
And number 3 is to create additional formalized recovery planning activities for the final 10 days of program. And this may keep clients engaged in program during termination phase, reducing perceptions of early completion of treatment goals and boredom in the final weeks. Our measures, so we were pretty focused. Our outcome measure was like completion rate being raised for kind of everything. And these are broken down by the 3 change ideas we had. So the first process measure will be that 90% of clients have been introduced to a peer helper at admission. Some of the unintended outcomes that we saw was either the client being admitted it could negatively impact their admission. It could also negatively impact on the peer helper's treatment experience. So we were going to do client and peer helper ratings. We included OPOC question 5. Completion rate, so for the staff scheduled check-ins 3 days in, again, 90% of clients would have received a rapport building session, and measurement of additional staff time. And our first 2, we had decided we were going to put in place first the peer leader, because it actually may have the unintended consequence of relieving a little bit of staff time, because we were going to have them do the orientation tour of the center, which actually is normally done by staff, which may have been able to balance off the extra therapy session. And then we also had OPOC number 20 and 21. And then the third one was 70% of clients actively engaged in the additional treatment planning in the final week of the program. And The measurement of additional staff. Sorry, my little thing keeps covering up what I'm trying to read. Measurement of additional staff time required for completion, and then client feedback on additional activities and engagement in OPOC number 27, 28. This is our run chart of early discharges. This is the only run chart we had. So we actually didn't get to implement anything. So our date for implementation of our first change idea was actually March 20th. And March 20th turned out to be the day that we put a halt on admissions to our program so that we could retool for COVID-19. And I'm going to show you guys at the end, because it all kind of lumps together, what our sustainability and what our measures are going to be into one much larger project now. Results and highlights. So our testing date of our first change idea ended up being the day that we paused admissions due to restructuring related to COVID-19. Our restructured second phase treatment model and physical distancing made the peer helper change idea impractical at the time, as well as our staffing levels. And interestingly enough, we independently put in a 3-day rapport building session in our brand new 14-day pre-treatment safety program that we put in. It's a very different program. So when we kind of collect data, which we're doing through a peer reviewed research project with Ryerson, it will have that, but with the understanding that there's actually quite a great deal of confound because it's a very different program and it's a very different experience for the clients. And the session isn't completely the same either, but it will give us a little bit of a feeling of client contact at day 3 in our context. Organizational enablers. So organizational assistance proved to be less important to our ability to implement than COVID-19, like I think a lot of people found. Future implementation and testing is going to require us to dedicate some resources in the form of staffing when we actually go back to active admissions to all 3 of our centers. So we are admitting clients and we are treating clients, but we're doing it in a very different way that I'll describe on a later slide. And this is where I see this and incorporating it into our other data collection as being really important, because when we go back to kind of live admissions to all 3 of our centers, it's going to be a very busy time for our staff as well. And if we don't do it at that time, it'll be very difficult to do afterwards. And like I said, we're going to incorporate it into our data initiative, which is focused on virtual delivery, a level of care model that we put into place, and a 2-phase treatment model as well. So as I said, when we do direct admissions to our 3 centers, it's going to give us an opportunity that we actually didn't foresee in being able to implement and test both of these first 2 change ideas with a brand new client community. So we won't have a client community where half of the clients that have been there for a while didn't receive the peer helper session and half did. We're actually going to have a complete new testing ground. And our eventual findings will be interesting to other residential outpatient program providers, including our new outpatient program. And this will be shared as a component of our wider measures. So in response to COVID-19, when we, on March 20th, we paused all of our admissions to our 3 centers. So we have 90 beds spread across 3 different centers. And normally, the Panani Center, Monroe Center, and Sullivan Center are all 28 to 42-day residential programs. And our decision-making when we were developing this was based on client and staff safety, but also our infection response our goal was to be able to take a full outbreak in one of our centers and continue to service and admit new clients 14 days after. So we wanted to not be shut down to providing care. So we launched this on April 20th, I believe. And what it involved actually was the family program, our continuing care program, and our alumni program all went to completely virtual very quickly. We then turned one of our men's centers into a 14-day safety center, which was a pre-treatment center with medical staff on site. We did all our admissions to there, and then after 14 days, we would admit to our female center and our male center. And we also connected with some partner agencies to be able to have them do observation for 14 days and admit directly to our other 2 centers. At the same time, this kind of dramatically lowered our capacity, probably to about 1/3 of what it normally was. And there's distancing in all the centers. So we also launched a virtual outpatient program at the same time. Not much of this, like for example, the 14-day program is co-ed. Renaissance never done a co-ed program before. The outpatient program, we had never done an outpatient program before. Like a lot of this was really super new. And our intention was to do it as quickly as possible. So it was like a very rocky implementation with a lot of lessons. And we needed to make a decision on who got into, so this is a lot of our QI on the fly stuff. We need to make a decision on who got into treatments and who went into outpatient. So we actually did a literature review and then developed our own risk of harm model for treatment matching to set a very high bar. These are our criteria, but so pregnant and actively using sole provider of care, immediate risk of overdose, acute risk of suicide, severe untreated mental health distress, immediate danger of physical injury or illness, and acute isolation challenges. And the bar for these was set actually very high. For example, acute risk of suicide would be like suicide, a suicide plan within the last 90 days. And part of what we're going to incorporate and are collecting data on is there's often a question in residential care about how many people actually need to go into residential treatment and how many could be served in outpatient. So our initial findings are actually that even with this incredibly high bar, 59% of our clients that had been scheduled dates actually met these, meaning that they were in danger of enduring their loss of life within the first 90 days, which was a pretty interesting finding. And that's the end of my presentation. I went through that incredibly quickly.
Thanks, Michael. That looks great. Any questions for the team from Renaissance?
Michael, it's Debbie. Some outstanding work and some great lessons for other treatment services across the province. Just wondering about the numbers at the end and some of the findings around you know, who met criteria and who didn't, and sort of next steps around that.
Yeah, so that's really our first look at it, and that came out of a presentation I did to our board yesterday. And okay. our focus was on data collection. Our staff has been really quite close, really stretched, like many staffs have been. So our focus was on data, making sure that we were collecting data, not necessarily making sure we were organizing data, with the plan that we would be able to at least go back. And so we've started that process now, particularly in our outpatient program. And then, like I said, we were actually involved in an outcome study, a multi-year outcome study with Ryerson, and they'd done the first phase. Which they actually can't use right now because of the dramatic change in our program. It's not the same measurements. So they're actually redoing phase 1 for our 2-phase model, and then using that as a measurement. So the part that we still haven't dug into in the risk of harm model was how many people met each criteria, which we have data for. And we also want to widen it out a little bit because our risk of harm model is vastly higher. The bar is set vastly higher than any other level of care. So when we start to include things like previous treatment attempts, I want to see where I'm imagining our number is actually going to be very close to the amount of people that come to treatment. However, we have found some interesting things in our outpatient program. One of them being that we thought it would be really useful to support clients on the wait list in the future. We also have plans on using it in order to reach marginalized populations and kind of as a pre-treatment. And some of our clients were actually alumni who had gone through our residential program and had a relapse and were now in our outpatient program. And those are the ones that actually seem to benefit really greatly from it. Like they've made comments like, this is actually the perfect level of care for me to get back what I had learned in residential, which we didn't actually expect. So
Right,
our
right.
next couple months are going to be a lot of looking at all of this and
Yeah.
the data that we've been putting in, probably
Yeah.
dedicating 2 people to organize it into spreadsheets.
Yeah. So please know we're happy to help with that. It's some pretty fascinating information. And the other thing that I just wanted to let you know about, which may be useful for you, is CAMH is about to release a virtual questionnaire, which Deanna keeps telling us it's imminent, maybe in the next couple of days, but specifically to ask some questions about virtual care and clients' experiences around virtual care. So as soon as we get that, we'll make sure we get that to you as well.
Yeah, that would be great. Like we've been working on our own, but if there's something that's going to be shared across organizations.
Yeah.
Plus it'll be standardized, right?
Yeah.
So we'll all be asking the same question. Yeah, they haven't figured out how to put the data anywhere yet either. That's more important to get the questions asked.
Yeah.
So we support the way you did it.
Thank you.
Other questions for the team from Renaissance?
I have a question.
Yeah.
Great work on presentation, Michael. I remember you mentioning in the beginning about reviewing qualitative data. So if you can comment on how did you collect, or was it just the OPOC surveys, or were there other means of like focus?
Yeah, the source for those was actually, it's an internal document, like an internal report that we do every time somebody doesn't finish programming. And it kind of asks 4 questions. It's a mismatch report. And it has 2, its original intention was to see if the mismatch was preventable. But one of the questions is a description. So what we had to do was actually go through each of them and kind of categorize by the counselor description, what category that they fell into. That is something that we're looking at changing going forward, because it's not, although it's very like context-rich data, it's not very accessible. It took a lot of work to go through, and it's being filtered through a couple different perceptions by the time it gets onto somebody's spreadsheet. So we kind of had to go with what we had, but we're looking at trying to find a different way to collect that, record that.
Yeah, it's so important to review the open-ended questions, and happy to help you in that if you want to further help with.
Yeah, that'd be great. Thank you.
Michael, thank you for sharing all information with us, and gone through quite a bit in a really short period of time. One of the things that struck me in one of our conversations, and I'm not sure that you shared it today, but I wanted to bring like a creative way of utilizing your staff in the COVID situation. And so you had the staff in the 14-day isolation program. And then that staff would take time off.
Yeah.
And during that time off, they were providing virtual care while they were in their own isolation, and taking a break from active in-person service, which I thought was a really creative way.
Yeah, it was really creative. It was necessary at the time. So yeah, so client counselors, there's actually 2 of them on the call right now. Martha came over from our Monroe Center, from our normal female center, to work in the isolation center, and John works there as well, or in the safety center. And we originally split our teams into 2 14-day cohorts. They would get a mental health break for one of their weeks off, and then one of the weeks they would do virtual programming. And it was a way to do it at a low initial investment. What we found is that having consistency of clinicians in virtual is far more intense than in residential. And then that's some of the feedback we got from clients, was that they would build rapport with counselors, and then they would have all new counselors the next week. And the other part of it was each cohort of counselors would need to learn how to do virtual care each week. So it was kind of it was an excellent solution when we didn't have any resources. What we've done now is fully staff the outpatient program and bring on a supervisor who's also on the call. Alex has joined as our outpatient supervisor. And we actually stepped out of the 2-team model in the safety house as well. And we have that as a model. It's really sustainable during periods of accelerating risk in a pandemic. When the risk starts to go down a little bit, it was one of our first kind of steps down to lower infection prevention. But having to go back to if cases start to climb again.
Great. Thanks for providing that detail. I thought that was really important to be able to share that. I thought that was really great.
Martha, I don't mean to put you on the spot, but having done that, can you shed any more light?
My gosh, I would love to. I have to say that it has been one of the most incredible experiences being a part of all this. The fact that we did it so quickly. I noticed that the 3-day sort of touch base with the client session that we were implementing in the new programming was extremely beneficial as far as building rapport and having the client feel cared for. And I really noticed how much I think can be missed if you don't have that earlier on sit down with the client. And a lot of the times I wasn't even really so much focusing on the structure of what we needed to cover so much as allowing the client to sort of express where they're at and what their needs are. The virtual experience was amazing because there's a lot of feedback I'd love to give Michael maybe one day, just a sit down, but briefly in considering the forum that we have right now, I'd like to say that I found it incredible how, first of all, the first session with the group of them was very challenging for me. I felt a lot of the disconnect that you can experience, like we're experiencing right now on a Zoom meeting, right? But how quickly we all kind of adjusted to that, and how we were able to connect even though we were on a virtual meeting. And then I was like, the second day it became very apparent that whatever was started, and they all had any length and you can't, we're changing all the time and this and that and the other thing. And by the second day already, the clients had adjusted to it all. It was actually fascinating to see this, how quickly they just adjusted to everything, and there they were opening up and how they liked the challenge, and the whole experience from one day to the next changed in such a positive manner, where the first day I was like, oh my God, that was horrible. It became, wow, this is actually very beautiful. And yeah, so there's no question in my mind that the therapeutic value of this form of treatment virtually for people that can't access, say, residential care for whatever reason, is valuable, and definitely something that has been a positive thing in light of the COVID crisis. That's all I'm gonna, right now, that's all I'll share, but you can ask questions. I can expand if you want.
Thanks, Martha. That's really great. I'm glad that there was an improvement in their experience over that short time. That's a really interesting finding for sure. I have one question for you, Michael. I know one of the things you talked about in terms of sustainability was the importance of the leadership role. And I know one of the struggles that you had as a team was some of the staffing changes that happened at Renaissance during the period. Can you reflect on that a bit and how you see that taking you forward? And also, I need to ask, Alex, is that a picture of you, or are you standing really still?
Me?
Like, is that video? What is going on? He's so still.
Sorry about that.
What, he might be working at the same time? Like, really?
Yeah.
Brown nosing, right.
The interesting thing is the staff changes were me mainly. So when we started the E-QIP project, I was the manager of one of our residential centers. And then in January, I became our director of programs. and actually had an acting role of it through the month of December. So the delegation is going to be quite a bit simpler now. And, you know, what we're doing right now is trying to find staff time for delivery of programs. But then also when we do move to doing direct admissions to the 3 centers, we're probably still going to be in a place where some of our staff are not coming into work because they may have be immune compromised, or so we're actually going to have higher staff levels, and we're slowly ramping up client levels. Also, we reshuffled our staff. So we took some of our staff from the Monroe Center into our isolation center, and once we do go back, they'll be going back, and they had been backfilled. And the Monroe Center is actually where we're going to be launching these change ideas kind of one at a time. So the plan is that even though we would reduce our relief coverage normally, we're going to keep them on so that we can do this while we're trying to figure out both. Does that answer your question?
Yeah, it does. I mean, I think it's just, it's something that all organizations deal with, and it's how do you adapt, and how some of it is QI culture, especially so dependent on the team that's there. And so as that shifts and changes, how do you sustain that?
Mm-hmm. Well, and yeah, and the other part is the team that we have actually predates our E-QIP project. We had set up a data and measurement quality improvement committee, and then we applied for E-QIP. So this is actually a permanent committee that will be meeting in this form, and we'll have new members joining on, which will allow sustainability to be a little easier.
Thanks, Michael.
Welcome.
Do you, are there any other questions for the team from Renaissance? Okay, I'm going to suggest a 5-minute bio break before we do the final set of slides. Oh, look at all the happy smiling faces suddenly. So can I ask if we can join back here just at 2:41? Thanks, everybody.
It'll be worth your while to come back. Oh, dooley dooley. Oh no, dooley dooley. Where am I, dooley dooley? Where am I, dooley dooley? No, 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 where dooley dooley? There she is. Oh, hi, dooley dooley. Hello.
I think you need to put Dooley Dooley on the screen.
Sorry, I'm going to eat while we present because I haven't yet.
Oh, that's important.
That's what they tell me.
I realized I hadn't had a drink of water yet, so I went and grabbed a big glass.
So Laura, I think whenever you're ready to get going.
Okay, I will do so. Okay, so I'm always challenged to kind of ground myself in starting up with the sustainability piece after being so uplifted and inspired by all the work that has been happening. And so thank you to all the project teams for staying committed to working through the model for improvement, attending meetings, including us coaches in those meetings, and staying true to that process. I think, but most of all, staying the course amidst the global pandemic. So I think that deserves a multitude of awards, and it's really inspiring to see you still continuing to do quality improvement, even though it is on the fly. So with that, having heard back from everybody, talking of sustainability, what we want to go through today is just give you that overview of some of those common sustainability mistakes, challenges that we experience as coaches and as pro teams, and give you some tips on how you might want to start thinking about, if you haven't already, planning for sustainability. Take you through the NHS Sustainability Planner, and give you some next steps that you might want to look at from a sustainability perspective. We'll also introduce the Ontario Health Spread Planner, which may interest to some of you who are thinking about using your idea across programs in your organization. For example, I'm thinking of HA Windsor X, comes to the top of my head. And then sharing your work and opportunities to stay connected with in the E-QIP community. And this is an infographic that is very familiar to all of you, and that is this the stages of QA. And what I just want you to do is celebrate, clap your hands if you wish, and throw your emoji or reactions up on the screen. You actually made it down to the sustainability and spread. So through back in September, it seems like such a long time ago, we started looking at preparing for your QI project and thinking about, you know, what data you might have, what are your staff telling you about what your problem is, and then hashing that all out through the W2H, and then starting to develop a project order. And then we took you through understanding your problem, and you utilized and saw great examples of today, the fishbone, 5 whys, the process map, the Pareto chart, and an aim statement. We saw all of those tools used today. So that was really great to see that. And then we took time, and our data coaches helped us with developing those measurement plans. The balancing outcome and process measures, and then displaying that data in a way that tells a story on those run charts. And that was really exciting to see run charts being used as well. And now the exciting part, which we all were excited to see, was the ability to start looking at our problem from the perspective of how we're going to solve it and creating those change ideas. And I don't know about you, but that was really great to be able to get to that stage of your project work and get those creative juices flowing. So here we are at sustainability and spread. I guess, yeah, we can just go to the next slide there. And so there's 2 typical frustrations that we note when looking at sustainability and improvement. One of them is improvement, evaporation. The other one are islands of improvement. And so our little friend here on island is sitting there, and he's, you know, he's done some really great work about how to survive on that island. But there's maybe somebody else on another island who is recreating the same and going through the same issues and creating something new for himself, but they're not sharing the information. So wouldn't it be great if they could, you know, put a little message in a bottle and share that information across the sea? And so thinking about how we can do that. And then the improvement evaporation is that lack of sustainability in terms of, one of the examples we like to say is that if somebody was doing it doing something for the organization. So for example, and I think Margot, you shared with this one about, you know, you have one person dedicated to pulling data for your organization. And that person is doing the work for all the programs all the time. And if that person's not available, then you have to either wait, or if that person goes on vacation, that information isn't accessible. So making sure that you have sustainability pieces that allow you to collect that information, no matter who's in the role, that you have other people that can pull that data. So just something to think about there. And then we often get asked, it's important from a context building perspective, is what is sustainability? And there's several points here, but it's just about maintaining the gains of your QI project over the long term, so past the life of the project. And what we found is that things like supportive management structures to error-proof the change, robust, transparent feedback systems, organizational systems, there's a shared sense of what that is. There's a culture of improvement and deeply engaged staff, which you all have, and formal capacity building programs are part of what sustainability is. And then if we look at what it involves, and the doing part of it is standardization, documentation, and regular and repeated measurement and review so that you can ensure that the change is sustained and the change becomes part of your routine practice. And of course, training and education of your staff and of your clients as well. On the next slide. So when you're thinking about sustainability, there's some areas you might want to pay attention to, and one of them is around leadership engagement. And so thinking about a change idea perspective, think about who needs to be on side for those changes to happen. Who do you need to have alongside you to make sure that those barriers are removed? And we talked about that at the exec sponsor session as well. And who ultimately influences whether or not something happens. So who is the decision maker that can be part of your project team or involved in the work that you're doing, and where the organization's leadership team actively engaged in the QI initiative from the get-go. So it doesn't mean that they're sitting at the table doing it with you, but they are, the work of the table is being communicated back and forth between the executive sponsor, leads, and the project team itself. On the next slide, you want to involve and support your frontline staff. So making sure that your frontline staff are involved in the very early stages when you're trying to identify what the actual problem is and getting to the root causes. And also part of the development of the solutions that you're going to be testing. It's really important to have that involvement. And then in the later phases, monitoring that improvement. So as you continue to ramp up your PDSA cycles, continuing to measure. And then in those later phases of a project where the frontline staff are identifying those training needs, potentially actually delivering those training pieces for you is a really great way to involve your frontline staff and improve sustainability of a project. One of the things that I think is we have been working on with our project teams is developing good communication plans, and where need, and that by communicating the benefits across all levels of the organization, it's really helpful in sustaining the long-term gains of your project. And when you're thinking about communicating the benefits of your improved process, think about asking yourself the question or answering the questions, have those changes address the root causes of your problem? And can you measure that? And does it meet the needs of all the stakeholders that are involved? And if the improvement activity is linked to the strategy or the vision of the organization, and we heard great examples today of how that project work is linked to the strategic goals and aims of the project work. And on the next slide, we are looking at looking at the PDSA cycle and how that change is adapted into your systems. And if you have completed your PDSA change cycle, that's great. But if not, it might be too early to consider full implementation and sustainability. So it's really important to follow through and have 100% uptake of a process through those PDSA cycles before you start to look at implementation. And change is likely to be integrated into the organization's culture if it's perceived as an less likely if it's perceived as additional task. So if you're adding to the burden of your staff, you will have less likely that your change will be implemented into their regular work. And it will also have to be higher perceived value to be able to be sustained. So making sure you have those two pieces when you're looking at change ideas will really help increase the likelihood of sustainability of a change idea. And embedding the improved process into your practice is really, I think, key, right? So making sure that it's well integrated into your core process of your practice that you're changing, or the process that you're changing. And also that it is flexible and is able to respond to changes in the environment. And then when we look at change ideas, and you might remember this from our change ideas session in February, where we talked about change ideas following the 5 C's. Yes, we do use a lot of these letters and numbers in the QI, but the 5 C's are conspicuous, contiguous, context, content, and count. And conspicuous is that it catches your attention, so that you're reminded to follow all the processes all of the time. And contiguous is in time and space necessary to the action. So making sure that you're putting a hand washing sign, for example, next to the sink, not next to the filing cabinet. And then in context, meaning that that it provides the correct information on when and where the new process should be followed, that it has enough information about what needs to be done, but it is concise, so not this long rambling list of information, but very succinct. And then at the count, it identifies, if needed, the number of actions required and limit the decisions and choices that an individual has to make. And build in that ongoing measurement. So we talk about measurement quite a bit in as part of our coaching for E-QIP, and how do we find that meaningful data? So now that you have found that meaningful data, do you have an ongoing monitoring system to measure the future performance of the improvement? And is there a standardized way of communicating those results back and reinforcing that the change is important, that practice that you've created? And a lot of times we talk about hardwiring change, and changes are tested in a variety of conditions, and majority of the staff have tested the changes and provided feedback. So if you can check that off, that's one of the ways you can think about, are you ready for wiring the change? Are the improvements in the process clearly evident on run charts or control charts? So the run charts, being able to see that change over time, and interpretation of that run chart tells you that you have that evidence that tells you your improvement is working. All shifts have been trained in the system and the new way of doing things. And then have you put any thought into what it looks like from a new and temporary staff perspective? And then having all the necessary supplies and equipment and the forms are in place. And I'll just add here that you want to get rid of those old forms that you used to have, and make sure it's a forced function that they have to use the new form. And then on the next slide, the other 3 points here related to hardwiring the change is that you have identified, again, this is about the monitoring piece. It's a small set of measures that monitor your performance of that change over time. And an individual has been assigned the responsibility for monitoring the performance, and there's a plan for communicating the results to the C leader, so that there's that part of that communication plan back and forth. And if performance declines, how are you going to address that? And make sure you have that laid out for your project team in advance, finding out that the performance may have started to decline, and then having to figure out how to work around that. And then standard work has been developed and documented. So Noshaba, in a second I'll get you to open up the tool, but this slide here is, I want to give you the link here for the actual guide, for the NHS Sustainability Guide. And the sustainability model is the tool that's been developed by the NHS, and it's used to predict the likelihood of a sustainability score for your improvement project. And the other thing I wanted to note here is that just because we're talking about sustainability at the end of our coaching support, it doesn't mean that you stop thinking, that you have to start thinking about sustainability now, that you should be thinking about it at the beginning of your project and all the way through assessing that. So just throwing that out there as well. And so on the sustainability guide, Noshiba is just going to pull that up. And I just wanted to show you, if I could, today.
Are you seeing it now?
I am, thank you. It's teeny tiny though.
Oh, is it?
Mm-hmm. Or is it just because I have my screen minimized at my end here, maybe? How is it for everybody else? It's fine? Okay. All right. It's just me. Okay, so for the sustainability guide, it really is, and I'm just going to start out by saying, we have found it to be a useful team tool in the sense that you want to have this part of what everybody on the team completes. So not one person fills it out for the organization or for the project. You actually take the time and have everybody go through it independently of each other and then come back together and have a conversation about the results. So, and then you come to a consensus on what you think, because I think that helps. On project teams, you often have levels of the organization sitting around the table, and everybody's perspectives are different. And it helps identify where things are different between the different levels of the organization, for example. And so it's broken out into factors, and each factor has a description about questions you might want to ask as you're having the conversation independently, well, having a conversation with yourself, or around the table with your team. And this example here is the benefits beyond helping the patients. So in addition to helping the patients, are there other benefits? So thinking about that, because it would be great if a change idea or an initiative actually impacts both client and staff, or client and family caregivers, for example, or another organization, right? So to have that two-sided of it. Does the change reduce waste or avoid duplication? Will it make things run more smoothly? And will staff notice a difference in their daily working lives? And when you think about the difference, is it a positive difference or a negative difference? And so you select whichever one of those answers makes the most sense for you in your context and your project at your organization. And there are no right or wrong answers, it's just an assessment. And then the next one is a credibility of the benefits. And then there's a series of 4 questions there that you can ask to help generate a conversation and thinking about it, and then reading those statements, then pick the one statement that means something to you, and then move on to the next factor. And the tool goes through this all the way on all 4 aspects of the tool, which is around organization, staff, and process. And then at the end, it generates a report for you at the end with your results. And the blue is the survey response, so that's your answers. The light gray is the maximum score you could achieve. And so then you can with self against that to say, okay, well, we're doing really well as far as infrastructure and sustainability. Our project fits with the organization's strategic aims and goals. But look at that, we're a little low in the effectiveness of the system to monitor progress. So we might want to take a closer look at that and find out why we're scoring low in that area. And then the challenge is then to create an action plan that will address those areas where you've have those worse scores. And so then if you go to the slide deck, Noshiba, thank you for navigating that for me. What I wanted to share with you is on the next slide, which is overall score, have 45 or below, your reason for concern. It doesn't mean you failed. You just need to take a closer look. There's some good signals that are telling you that you need to look at a little closer. If you're over 55, sounds like Shoppers Drug Mart and your seniors discount, doesn't it? I'm not there yet. And you have reason for optimism, right? So over 55, reason for optimism. And then if your score is low 35, some advice that you might want to spend some time concentrating on those improvements that you'll need to make in order to sustain the project, and that you actually suspend the project until you've affected that. So setting out those action items and trying to turn that around in a really short period of time so you can move forward on your project. And then work on improving the 2 or 3 factors I mentioned, creating those action items, and then take the time to rescore yourselves in about 6 to 8 weeks. It doesn't take a lot to complete the assessment after you've done it the first time and had that walking through of it. Then in 6 to 8 weeks, you complete it again and see, did we make any change on that? And so I'm just challenging you to think about what your next steps are in terms of assessing your sustainability of your QI project. And were there things in there that you were thinking about that, oh, maybe I should take a look at that a little closer and see if there's something that we can impact in that regard. So I'll stop and just check to see if any questions before I move on to the spread planner. Silence. All right. So what is spread? Well, there's all kinds of difference out there. I just had a friend of mine text me this morning to say she just opened a jar of wild blueberry jam that I had gifted to her in 2017, and that she's been saving it for just today because she made sourdough bread. And so she took out the warm bread out of the oven and had blueberry jam, wild blueberry jam on it. So I put this on the slide deck yesterday, not knowing that she was going to text me about blueberry jam. Anyways, I digressed. But the science of taking a local imprint and actively disseminating it across the system. So once you've figured out the recipe of jam that works for you, and you got it to gel, and it stays nice in your jars in the cupboard, then you can say, okay, I'm going to share my recipe with my friend down the road. I'm going to give them a jar of my jam to taste. Yes, blueberry rhubarb is my favorite. Yeah, St. Jacob's Market. Yeah. Yes. Marmalade, yes.
Definitely have a small poll going on the preferences for spread.
Yes, yes, I like it.
Not the same type of spread as we're talking about.
Not the same type of spread, but I'm trying to make an analogy here. I don't know if people are getting it though.
I think they're focused on the jams now.
All right, we can move on to the next slide.
Is there more jam?
I'm hungry. Oh, sorry. Yes. So taking your recipe and thinking about who else might benefit from this. And so thinking about, and one of the slides as part of your presentation report back was, who might you want to talk to about the work that you're doing and include them in that, right? So consider key groups and stakeholders that would benefit from hearing about your learning. What is the best way to reach them? And we'll talk a little bit about, I think we're in the sharing part of our how to stay connected about how you might want to do that. So how do you get from that island of improvement to system level change? And it's really through those PDSA cycles. And so you're developing, and this is a great little infographic that kind of steps us through. You develop your change, you make a theory or a prediction of what you think the outcome is going to be, you run it through the test, and then you start to see that it's working, and you continue to test it under a variety of conditions and in different environments and different schedules and staff complements, and then you implement the change iterations. And then once you see, as you go through those PDSA cycles of implementation and making it part of your routine operations, a product that actually is consistently working, then you spread it to other locations. You share the jam.
Okay, Laura,
You
you got to
lied.
pause and read
Okay, okay.
because
Normally it
honestly,
doesn't-
this happened in our first report back, but it was a very different conversation about Star Wars and the Sith Lord. So just to give Laura a chance to catch up.
Yeah. Please. So this is not an assessment. This is a tool that you can use as a way to guide your conversations about understanding where your project work and the results of that project work are ready to be spread and shared more broadly. And there are 4 steps to spread. And the 4 steps, the first one is to clarify what's being spread. So prior to initiating the spread of a practice or idea, it's important for the team spreading the change to agree on what is being spread. So is the team attempting to spread a specific change idea, change concept, or even a new redesigned system of care? Without consensus, it's difficult to spread the sustainable change. Second one is determining how to spread the change. So the best way to spread a change will vary depending on the specific practices and culture of an organization. So for example, in some it might be that talking directly with colleagues might be the best way to spread change, and in others it might be that change to originate with the senior management or organizational leadership. So tailor your spread plan to suit your organization and your context. Identify and confirm resources. So spread improvement requires resources, the support of organizational leadership, someone to lead the spread effort, trained staff, and access to the necessary equipment will improve the likelihood of successful spread of an improvement. It's helpful to identify these resources early on. Monitoring and communicating your progress, and that's just about having a plan that outlines how you'll monitor and communicate the progress of your spread initiative. Next slide. Yeah, so the link is there for folks if they wanted to pop that up. And so it has all those pieces, those 4 steps that are necessary. And then the part that I really wanted you to see, I think this is a really valuable piece, this tool, is that checklist on the left-hand side. So as you're reading through those pieces, you can have a conversation about it and then write down what your plan is in terms of those check boxes, and then thinking about who's responsible and then reporting back on what the status is of that. So I think it's a really interesting little tool to work through. And then this piece here is that planning part around who are we spreading the change to, and the best way to reach that group, the message that you're going to give to that group, who will take the lead on that, and then the accountability piece of the buy-when. Yeah.
Back to the deck, Laura.
Yeah, sorry, Nosha, but thank you. And we don't have our telepathic stuff happening today. Yeah, and this is where my piece is going to finish off. We've worked through the model for improvement again. We asked ourselves, what are we trying to accomplish? You went forward and figured out what you were going to be measuring, and then develop those change ideas. Some of you had to test those change ideas. So I think I'm going to end there, but I want to make sure in this slide that we have an opportunity to answer questions that you might have in terms of it doesn't necessarily have to be a question around sustainability. If you don't feel led to ask a question around sustainability, that's fine. But we wanted to make sure you had an opportunity to ask any questions related to QI. Okay, so hearing none, feel free to type them in the chat box. Well, if you're inspired to do so, we can answer them on the fly. And then I will hand it off to who is taking the baton for the outro.
That would be Debbie. Starting, I think. Is Debbie still there?
Yes.
Yep. Okay.
No, but can you see her?
I cannot. Oh, look at the hat. Very nice.
Thank you.
On Tuesday, Debbie was dressed as a Sith Lord. For those of you who missed it.
On Tuesday, it was very cold in my house, and I had to grab a hoodie really quickly, and so I grabbed the one that was closest, and it has a very wide hood. So I was huddled under it, freezing to death, and there was a whole discussion about being a Sith. And I was just trying to stay warm. You know, there was just nastiness going on. They were very, very bad.
She completely distracted John Ranger from CMHA Brent Haldeman in Norfolk. He was fully thrown off. I think he almost left the meeting because he was afraid.
I was a powerful being.
Yeah.
So we're on the home stretch here, and Bella and I have worked through exactly my part and what is his part, because I passed it over to him a tad early last time as well. So part of what we're hoping you will do is to share, and we've made some connections over the chat, which we will be sending to you as well, all the content in the chat and all the positive things that have been said about your programming. So there's a variety of different ways to share information about what it is you've done. And part of it is connecting with people who are doing like work, and others is on webinars. So we have a number of webinars coming up, which we would love for you to be involved in. We have an online community of practice, which all people are invited to do, but even just to post something interesting that's going on, that you made it through presenting, one of your key findings, something exciting that went on. Social media, I actually tweeted today, and I tweeted Corey and Veronica's fishbone out to the big world. So these are ways of sharing the information that you've done and talking about it. It's always helpful if we don't have to start from the very beginning. We can have some lessons learned. You guys did some of the work in figuring out what works and what doesn't, so people can start off from where you are as opposed to having to reinvent the wheel all over again. And then sharing those experiences also helps keep it alive. It is your opportunity to brag, as you absolutely should be doing. You've done some amazing work, and you know, sometimes we are shy about bragging, but don't be. Next slide. So a couple of questions to think about, and you'll be getting these slides tomorrow, so you can spend some more time thinking about it and looking at these. But is there some questions that you could be asking of the team? What's the key lesson that we learned, and could you post that on the community of practice? What are some of the challenges that we encountered, and how do we get over those? And could you post that on the community of practice so that others can learn from you across the province? And thinking about what information you'd like to share in your organization, and organizations that are like you, similar organizations that might benefit from hearing what you are doing. And again, we made some connections today, we made some connections on Thursday. We're actually doing some cross-pollination between Tuesday and Thursday groups. So that's very exciting, and hoping that you'll continue to be involved in those discussions. And I know we're in the process of doing a June Blitz and connecting with agencies we haven't connected with yet, and Michael and from Renaissance and Jean Tweed are willing to speak with one of our new Cohort 5 applicants about some of the virtual work that they're doing, and some great learning there as well. Next slide. So this group, are you ready to go on and do a quality improvement plan? Because it feels like you are. Some of you probably are doing that already, and you started to do quality improvement plans as part of how you report to your boards about what it is you're doing. We have an advanced community of practice, which Amy coordinates, and it is an opportunity for you to join that coming this September, and we will help walk you through how to do a quality improvement plan that you will be submitting just to your colleagues in April 1st of 2021. That's a very long ways away, but some great work that you would do to do that. And again, using some of your skills, going through the exact same process and thinking about how you would do a quality improvement plan that you will then implement from 2021 to 2022. So we really would like for you to do that. And we're hoping that you'll be involved. The other ways is we would like to post your report back, so these slides that you've done. So for those of you who made some changes or we're sharing the screen, if you could send those to us, we'll put them up on our website. Another way of people connecting with you and what it is you did. And also, just as an aside, those report backs can be converted very nicely into a poster. So if you would like to go and present virtually or to present live one day when we're able to do that in some exotic place, and that's why I have my exotic hat on, you will be ready to go. You just have to send it to the printer and they will put it into a poster format for you. Roll it up and away you go. Maybe just to your living room, but you know, there's hope one day. Next slide. So again, a newsletter story, and we're looking for a newsletter we can do this September. Community of practice, which I mentioned, sharing through social media, and I heard Q on the fly numerous times today, which was very exciting for me. It's almost become a dictionary word. So we're that close to converting all of people into quality improvement on the fly. So great work for all of you. If you haven't done a template with us, we are happy to have that conversation with you. We'll type it up, send it back to you to fix it. And again, we're storing those very shortly on our website, and people will be able to have a look at that and hear about the great work that you did. Next one. So here's our bouquet of opportunities, and thank you to Melanie for putting this together for us, one of our newest quality improvement coaches, along with Rishi. So these are all the ways that you can connect. You obviously have been in part of a cohort. Is there an opportunity for you to go on to do a quality QI on the fly template with us and to think about some shorter version of what you might want to do? But most importantly, I really would love for you to think about being part of the community of practice, whether and starting that in September, so that we can help you to get a quality improvement all fresh in your mind. And then all the different learning opportunities. We're happy to come and do some board training or some leadership training. And we can tailor that. We've got a couple of those coming up as well. And we are currently doing a QI on the fly webinar series. We've done 4 so far, one yesterday, and poor Laura has been presenting for days in a row now. Surprised her tongue is still working effectively for her. But anyways, she's doing great. And so we have all of those stored on the website, on the E-QIP website, which is just e-QIP_.on, and so you're .ca, sorry, that's I was giving you our Twitter handle. So you're welcome to have a look at that, and it's a great place to get resources and also to see what other people are doing. Next one, Urban Dictionary. Yes, that's a great idea. So this is where I handed it over to Abel, and he's not going to let me do that today, as it wasn't his slide yet. So this is Quorum that I keep speaking about, our community of practice. If you're going to be involved in the advanced community of practice, that's by invitation only, so you are a unique group being involved in that, and I hope you will consider that very seriously. And again, your whole team is welcome to join that. And there's great discussions that go on there as well. And then we meet every other week for an hour. So not a huge commitment, and we will walk you through how to do a quality improvement plan. But on Quorum, you can post stories, you can post information, you can ask people to help you with a question that you have. It's a great way of connecting with those who are interested in quality improvement. And then if you click on the subscribe update, it will let you know when there's a message. Now, you're not going to be overwhelmed. There's not a huge number of messages that come, maybe 1 a week, maybe 2 a week, so it's not going to be overwhelming, but you then will be able to know that there's a message waiting there versus having to go and check it out. Next slide. So one of the things that we're hoping will happen is a forum discussion that can happen, and we try to do this after each report back. So it's an opportunity for each of you, your executive sponsor, your leads, your team, to kind of talk about what it is that really worked for you. What were the lessons learned? How would you help somebody to get started? Those that are dancing around getting involved in quality improvement sometimes need to hear from real people like you that this is really not so hard, that this is doable, this is how we went about it, these are the things that made it possible, and we did learn something in the process, which I'm hoping all of you have. So a great way to post that if you would. And the evaluation, so we have, Daria normally does our evaluation, and she gives a call to people to ask you about what it is that was helpful, what was the impact, what are some of the changes that you've made in terms of your structure and your culture, what are areas you still want to work on. So that is coming up, and it probably won't happen until the fall, but just wanted to let you know that there will be some evaluative questions that will be coming out, and we hope you'll take the time to complete those for us. As well as, while I'm on this slide, I'll just remind us that each of you would have done a pre-assessment of your team and the strengths of your team and areas to work on. we're now inviting you to do a post. And those are pretty important measurements for us. They help us to talk about it at the Ministry of Health level about the impact of the E-QIP program for community mental health and addiction agencies. So I'm really hoping that you'll take the time to do that. It is, again, the team contribute their thoughts, then come together and finish off that. Find your consensus around the answers. We are more than happy to be involved in that conversation and facilitate that conversation. So to be on the phone with you or on a Zoom meeting with you to complete that post questionnaire. So just naming it out to Middlesex that we'll be after you to get that completed. Next one. And here's just some of the things that that may be helpful for you in your next work. So reviewing your profile, which I just mentioned, adding that post, saying that again and hoping that you will do that. Signing up for any of the webinars that are coming up. We have a process mapping, which some of you are very familiar with and some may not be. Some new team members who you might be recruiting to be a part of ongoing quality improvement activity. They're all welcome to join and to watch those webinars. And we have recorded them if you prefer to watch it on your own time versus live. So again, all things to keep in mind, and you'll be getting these slides probably tomorrow to sort of remind you of all of these things. Next one. So two webinars that are coming up. This one is happening next Tuesday, and it's a QI on the fly for experience-based co-design, and it's how-to sequels. So we're actually demonstrating how to do experience-based co-design emotional mapping virtually and how you can do that and gather information. So if you can come to that, it's an hour long, it's an easy one to connect with, and we will get you to participate. So some fun times. Next slide. And here's a process mapping piece that I mentioned. We're offering it twice, once in July and once in August. It's exactly the same webinar. The purpose is recognizing that people are hopefully getting out of their living room for some vacation this summer, and so therefore may not be available for either. So you can come either in July or you can come in August. And most recently, the date is still being confirmed, but there is a virtual survey that's coming out shortly, which I know some of you will be very, very interested in. It's imminent when it will be released, and there will be a webinar in July for that one as well if we want to learn some more. So we'll get that information out to you as soon as we have it. And next one. Now I am passing it over to Abel.
Thank you, Deb. Yeah, so finally, before we wrap it up, so let's quickly mention some resources. It was mentioned, some of them, but going forward, let's just underline some of the resources you can use. Next slide, please. Yeah, sorry, before. Yeah. So we have our website, and it's brand new website, and actually we said it's graduating with this cohort. So it's a great source of information as well. So you can visit that, and there is also an E-QIP community of practice on Quorum. Deb mentioned that before. So there are different knowledge sharing activity there. So if you already didn't join yet, please join to this community of practice. And we are also active on Twitter. Our handle is #E-QIPON. So all these are great ways to connect, communicate, and share knowledge that we all learn throughout different journeys. Next slide, please. So we have also our E-QIP QI webinars and newsletter. We have conducted a series of webinars. If you're interested to learn more about different projects, different QI tools specific for the sector. The good thing, I mean, you can find other resources, on YouTube, but the good thing about E-QIP YouTube is very specific for the sector and it's based on our experiences. So on YouTube, contents are always updated, and we upload different discussions, educational materials, so you can enjoy those in your own pace. And our newsletter is also another way of connecting the mental health and addiction QI community. And it's a way of getting also up-to-date information on what's going on, what are we doing, and if there is any new opportunities as well. Next slide, please. Yeah. So here is also our contact information, as you can see, and we're growing. And you probably see new faces and new names there since we start this cohort. Yeah, you can also find our contact information from the website. Yeah, next slide, please. Yeah, thank you so much. It's quite a journey. It's a unique cohort, you know, given the situations, you know, around us. So personally, I thank you also to each team for your effort and for being so engaged and letting us learn from you and about your work, your organization. Yeah, again, it's all this, you know, with all this extraordinary challenge. Continue doing this this work by itself is it's an extraordinary success. Yeah, so thank you. Yeah, back to Nusha Whiting.
Yeah, so just I think that's it, everybody. Thank you very much for taking the time to join us. Please, for those of you, and it was Middlesex, Crossroads, and Renaissance, if you can send us your slide decks, we'll make sure to share those. So following this, we will be posting the videos. We will also post the slide decks to our website, and we'll share some information from the chat. Hopefully there are some pieces in there that will be helpful for you, and we'll do our best to make sure you've got that information as well. Probably it maybe not this week, maybe early next week or by middle of next week. So just look out in your email for that information.